All right. Good morning, everyone. Welcome. My name is Lupe Campos, and I have the honor of serving as the board president of the Arizona Rural Health Association. And we are grateful that you've joined us as we celebrate National Rural Health Day. The day was created by national organizations of state offices of rural health to shine a light on the strength of resilience and contributions of rural communities, and to recognize the organizations working to improve access to healthcare across rural America. National Rural Health Day serves as an important reminder of the unique healthcare challenges of our rural residents face, but also their incredible spirit and innovation. Today is about recognizing that strength, highlighting opportunities, and learning how we can continue to support and advocate for rural communities. Together, we can elevate the work happening across country and highlight the partnerships that make progress possible. At this time, I'd like to turn it over to our president-elect, who will walk us through a few housekeeping items before we begin. Thank you.
Good morning. My name is Carrie Foote, and I have the honor of serving as the board president-elect of the Arizona Rural Health Association. Before we get started, just a few quick housekeeping items. All attendees are muted during the presentation to keep the audio clear. If you have questions at any point, please drop them into the chat and we'll address them during the Q&A segment. Today's webinar is being recorded, and we will share a link to the recording and slides after the session. We also ask that you complete the short post-webinar survey. Your feedback helps us refine programming and continue offering relevant content. The recording will be posted on the Arizona Center for Rural Health website. And Lupe is now going to do our land acknowledgement.
Thank you, Carrie. Yes, we'll take a moment to offer our land acknowledgement. We respectfully acknowledge the University of Arizona is on the land of terrorists of indigenous people. Today, Arizona is home to 22 federal recognized tribes, with Tucson being home to the O'odham and Yaqui. Committed to diversity and inclusion, the university strives to build sustainable relationship with sovereign Native nations and indigenous communities through education offerings, partnerships, and community service. And now I'll turn it over to our president-elect, and she will give a brief overview of our Arizona Rural Health Association.
Thank you, Lupe. The Arizona Rural Health Association is also known as AzCRH. AzCRH was established in 1994 as a not-for-profit corporation dedicated to improving the health status of rural communities across Arizona. Before becoming an independent organization, AzCRH served for many years as the advisory committee for the Arizona Center for Rural Health, and that close partnership continues today. Our mission is to lead through partnerships, education, and policy efforts that strengthen rural health. We are also proud to be an affiliate of the National Rural Health Association. I'm pleased to introduce our current board president, Lupe, and I serve as president-elect. And if you would like to become a member of AzCRH, simply scan the QR code on this slide. Membership is open to anyone who is passionate about supporting and sustaining rural healthcare in Arizona. Lupe?
Yes. Before we go into that, I do want to say that we did receive the governor did sign a proclamation for this rural health day, and we will be sharing that on our website.
Thank you, Luby. It is my privilege now to introduce today's speaker. Dr. Carrie Cochran-McClain joined NRHA staff in 2020, where she is the head lobbyist for the association and is responsible for driving the organization's rural health policy agenda. She has more than 20 years of experience working in federal health policy development, including leadership roles at Health Management Associates, the U.S. Department of Health and Human Services, and the Federal Office of Rural Health Policy. Throughout her career, she has focused on improving healthcare outcomes, promoting health equity for vulnerable populations, and advising on healthcare policy issues. She earned her BA in sociology from Willamette University and MPA with a concentration in health policy and management from the Maxwell School at Syracuse University, and a doctor of public health from UNC Gillings School. Welcome, Carrie. Please take it away.
Well, thank you so much, Carrie and Lupe and the rest of the team there for having me. It is my privilege to be with you today on, of all days, on National Rural Health Day. So my job today is to really talk with you about what's happening in Washington. And man, I wish I could trade places with you because my guess is Arizona is a nicer place to be these days than in here in the nation's capital. But there is a lot going on. So my goal is for the next 45 minutes or so to talk about that. I would welcome kind of questions if you have them along the way. I believe you have an option to share those in a Q&A bar that should be available to you. And let's go ahead and jump in. So for those of you that don't know the National Rural Health Association, we are a nonprofit, nonpartisan, member-driven organization. And we really work to provide leadership on rural health issues through advocacy, communications, education, and research. And when we talk about rural health, it is a big umbrella, right? It is all of rural healthcare, all of healthcare in a rural context. And so as my team and I are working on the advocacy portfolio of that, we kind of think about three primary pillars. First and foremost, and really is probably the foundation of our NRHA tent, is working to deliver opportunity to individuals living in rural area and really working to move the needle on addressing issues around life expectancy and health outcomes. The foundation of all of this, we want our rural communities to be a healthy place to live. Two other core areas we focus on are reducing rural workforce shortages, so making sure we've got a robust set of healthcare professionals in our rural communities, and then making sure that we have a strong rural healthcare safety net. Can our clinics, hospitals, and other types of healthcare providers, facilities maintain the services they need to take care of the populations in their areas? So with that context, today I'll be talking a little bit about HR 1. That is what many folks also call the One Big Beautiful Bill. I find it easier to say HR 1 than OBBBA or any other acronym you can think of. So we'll talk about what was in that, what does it mean for rural areas. We'll talk about what's happening here in Congress outside of HR 1 now that that bill has passed. We'll spend a little bit time talking about what's happening in the administration related to rural health. And obviously, there's a lot we could go over here, but I'm going to give some high-level overview and then talk about some of the advocacy resources we have here at NRHA, and then take time for questions. So with that, jumping into HR 1, again, this is the One Big Beautiful Bill or whatever other name you have for it, depending on how you feel about it. I think regardless of if you think it was a good bill or a bad bill, we know it is going to impact rural America. Medicaid was a big source of funding for the changes that were in in HR 1. And I think it's taking a step back. It's important to recognize two things, I think, about this bill. One is that despite the cuts we saw in Medicaid and other federal programs across the country, this bill has somewhere between a $3 to $4 trillion cost outside of the cuts. So right now, the bill is adding that amount of money to the federal deficit. The Congressional Budget Office, which does the math and scoring on legislation, continues to add to the cost of what this bill will bring to the U.S. deficit. So not all of the cost associated with the bill was accounted for, but it did take almost $1 trillion out of Medicaid and healthcare broadly. And a lot of that is going to come out of the Medicaid program. So as you all know, Medicaid is a lifeline for rural America. It plays a larger role in covering individuals in our rural communities than in many parts of our urban and suburban counterparts. So we know about nationally, about 20% of rural adults and about 40% of rural kids living in rural areas rely on Medicaid. So that's, you know, those are high numbers. That is a significant part of our population. The map that you see here is specific to coverage, Medicaid coverage in Arizona in 2023. With the darker the colors, the higher the concentration of individuals on Medicaid. So that lays the groundwork for where we are with Medicaid in the state. Now, thinking about HR 1, this slide talks about how over half of the spending reductions that we are going to see in Medicaid in rural areas really falls among 12 key states that have large populations and that have expanded Medicaid. So you can see Kentucky being the most impacted all the way down to DC, which, there is no rural, so that makes sense. You and Arizona are about right in the middle of that, meaning that there is still going to be a significant impact. And when we look at that in terms of anticipated dollars lost or kind of changes in reimbursement for rural hospitals, this is some work that we did with the Manat Health Consulting Group that ran some data for us that shows, oh, I'm sorry, that shouldn't say New York, that should say Arizona, excuse me. That shows that in Arizona, rural hospital expenditures, about 4% of that comes from Medicaid, so a little bit less than the national average. But with that, you can see the anticipated loss of dollars and what that's going to mean for the overall kind of baseline for rural hospitals. Now, you've also heard that the One Big Beautiful Bill, or HR 1, had an investment in rural areas called the Rural Health Transformation Program. And we're going to talk more about that program later on. But I think important part of the messaging that we're really using both with folks on Capitol Hill and in the general public is, while the Transformation Fund is a phenomenal opportunity, a once-in-a-lifetime opportunity to invest in our rural healthcare system and infrastructure, it is very different than the day-to-day reimbursement that we receive as part of Medicare, Medicaid, and the health insurance marketplaces. So while the $50 billion, it's a lot of money going to rural areas, it isn't enough to directly offset the anticipated losses for what rural areas will experience due to the bill. But even if it were, we know that the way the program is being implemented is not a direct one-to-one to providers. So there's lots of different ways that those rural health transformation dollars will be going to rural areas. A lot of that is state dependent. And so I think that's important context, because a lot of times people will say, well, rural will be taken care of by the Transformation Fund. And we know that that isn't quite true. So the changes to the healthcare landscape and the Medicaid landscape due to HR 1 are important for a number of reasons. And I'm going to go through a little bit about what those changes are. But one of the biggest concerns we have is not only the loss of coverage for all the individuals living in our communities and what that means for them and their families and their health, but also the larger rural health infrastructure that cares for those individuals. When you have the number of vulnerable hospitals that we have in this country, you really don't have wiggle room to make significant cuts to any of the payers in those communities. And again, with Medicaid covering 1 in 5 adults in most parts of the state or most parts of the country, a cut to that is a cut to the rural health infrastructure and safety net. So that's always context we want to put here. So when we're talking about rural hospitals and we're talking about the vulnerabilities, this is part of the picture that was being discussed during the congressional debates. So what was in HR 1 as it relates to changes to Medicaid? I think of this really in two primary buckets when it comes to Medicaid. One is around eligibility and enrollment. What's changing for the individual that may impact their ability to get coverage? And a lot of that is around the debate and implementation of the work requirements, which will be going into effect in January 2027, so about a year from now. That will require folks to be working or volunteering, looking for a job, or going to school 80 hours a month. And then there are some exceptions to that, but we know that that is going to be a challenge for individuals, not necessarily to be doing, because we know a lot of our folks who are covered by Medicaid are working already, but the paperwork and the administrative processes involved with approving those work requirements is what folks are most concerned about. Accompanying that is a more frequent eligibility redetermination. So right now, individuals who are getting their coverage through Medicaid have to show their eligibility once a year. Starting again in January 2027, that will move to every 6 months. There's also timeframes that right now, if you signed up for Medicaid, you might be able to get your eligibility kicked back for a 3-month time period. That's also changing to a shorter time period. And other kind of factors, again, all around the process of getting and staying enrolled in the program. In 2028, we are also going to be seeing some cost sharing requirements for individuals, adults covered under the expansion population. So this is not something we typically see in Medicaid programs. We don't typically have a lot of cost sharing or co-payment requirements. So this is another area where there is some concern that it may dissuade people from getting care due to financial status. Across all programs, another element in the eligibility and enrollment category I think is really important to lift up across all of our publicly funded healthcare programs. So Medicaid, Marketplace, and Medicare. There is a change in the bill or in the law now that restricts lawfully present immigrants to having certain immigration statuses in order to be able to participate in these programs. And I can answer questions about specifics related to this. But it is basically restricting the definition of who's qualified to green card holders, certain Cuban and Haitian immigrants, and COFA immigrants, and excluding others who may be here under a different status, which again, we expect will impact the number of uninsured, and you can see the estimated growth numbers there. Going back to Medicaid, I talked about two buckets or ways of thinking of this. The first bucket of changes is in that eligibility enrollment space. The second bucket of changes in my mind is around financing and how the state Medicaid programs are able to operate their programs and fund their programs. And the two big changes in here are around provider taxes and state-directed payments. So provider taxes, while they may sound scary, are a big way of how Medicaid programs fund their program in the state, how states fund their Medicaid program. And those provider taxes applied to providers, but they also apply to health insurance companies and a whole range of types of entities that are in the healthcare setting. Those caps or freezes on how much states can tax, we think will have a pretty significant impact on the amount of dollars states have to fund their Medicaid program. The other area in state-directed payments, this provision allows states to take dollars in their Medicaid program, including those collected in provider taxes and focus on certain priorities or certain areas where they really want to be able to move the needle. So in many states, we have seen state-directed payments support funds to help rural hospitals specifically. We've seen funds go to addressing maternal mortality and kind of quality initiatives, all of which, again, are of importance to rural. So the concern here is as we are capping the amount that states can use towards these initiatives, it narrows the pool of resources that can give some of those kind of enhanced supports that the Medicaid reimbursement itself might not be able to cover. We are seeing states start to talk about what this means for their Medicaid program. When you are making changes to Medicaid, in the most simple of terms, there are three ways you can do it. You can reduce who's eligible for the program and change eligibility to bring down the numbers. You can change the services you're offering, and there are quite a lot of services under the optional category in Medicaid that a lot of us would think are not so optional in life. So they can change what services are being offered. And then thirdly, they can reduce reimbursements to providers. And in some states, we have already seen discussions about reducing those payment rates. So this is kind of, while all of these provisions are still being phased in 26 and beyond, this is something I think we're going to see a state start to proactively address next year. In addition to changes in Medicaid, we know that there were a few things in the marketplaces and in Medicare I just wanted to highlight. So a reminder, the ACA or health insurance marketplaces, sometimes they're called exchanges in states or in different parts of the country. Those are the platforms where individuals or small businesses can buy health insurance coverage for their populations. And so it's a really important resource for rural communities that have more self-employed or more individuals like farmers and ranchers who are employed by small businesses. The marketplace, the biggest change here is that most of us who have employer-sponsored coverage, every year, you get your open enrollment period, and if you're doing your due diligence, you look at what you've spent last year, and you look at what's being proposed in the coming year for coverage, and you decide to stay on your plan. I will be the first to admit that I do not do that every year. I say, hey, overall, I've been pretty happy. I'm just going to stick with the plan I've got, and you don't have to take any action. Well, now with the change to the marketplace, individuals who are getting their coverage through the marketplace plans will have to re-enroll every single year. Again, creating what we think is going to be an administrative barrier for people. So that auto renewal that a lot of us under employer-sponsored coverage have the benefit of will no longer be an option under the marketplaces. Separate from the HR1 conversation and part of the discussion that has shut down the government in October is another element of the marketplaces regarding how much subsidy is available for people to support the payment of their premiums. I'm going to talk about that in a little bit, but I think it's important to know there have been a couple of different marketplace related policy changes because the marketplaces, while we don't talk about them a lot, are really important, again, source of coverage for a lot of our rural families and individuals. And then under the Medicare umbrella, the big thing I wanted to highlight here is that I won't go into the weeds of it, but there was a concern because of that additional cost to the deficit that I mentioned before, that something called PAYGO was going to kick in that would create additional payment cuts under Medicare to our providers. The good news here, I just wanted to make sure was on everybody's radar, is that in the bill that reopened the government, the continuing resolution that will go through January of next year, that bill had a piece that offset any potential cuts to Medicare under PAYGO. So that is a little bit of good news that we don't have to worry about that going into place next year as well. And last but definitely not least, not specific to health, but definitely impacting training for our future healthcare workforce, there were changes made to education in terms of limits that limiting the amount that folks can borrow for grad school related to the amount of loan they can take. So there, in order to receive subsidized and unsubsidized loans, there are caps of 100,000 lifetime cap for graduate students, and then a 200,000 lifetime cap for professional students. We are hearing from med schools and nursing schools and associations that work with them that there is some significant concern that this is going to limit who is able to go to medical school, who's able to go to nursing school, because they won't be able to take out enough loan to pay for that training. So something to keep an eye on in this space as well. It's not retroactive, so anybody who's currently in this space with loans is fine. It's new loans going forward. I know I'm moving quickly through a lot of this, so I want to make sure I'm leaving lots of time at the end for questions. I'm trying to hit the high notes of some of this, but there's more content on the screen for you to have as a reference. And again, if you have questions, happy to answer those. So that all was the activity that happened at the beginning of this year through HR 1 and the reconciliation process. As you know, that bill passed on July 4th. So what's been happening in Congress since then, and what can we anticipate for the rest of this calendar year? Well, we had a shutdown showdown, to put a little rural spin on it. You all are very aware that we just came out of the longest government shutdown in history, which lasted 43 days. And that shutdown was primarily around the policy that I referenced before around extension of what we call the enhanced premium tax credits under the marketplace. I'm going to talk a little bit more about what those are in just a sec, but let me staying on kind of the budget focus for a minute. So the federal government budget cycle runs October through September every year. So we are already in FY26 budget for the federal government. And because the federal government couldn't pass, or Congress, I should say, didn't pass appropriation bills by October 1, we are now in what is called a continuing resolution. So basically, it's a short-term budget to get us to a place where Congress can decide on what they want to fund for the now current year for FY26. So that continuing resolution funds the government through the holidays. Thank goodness for all of us that live here in Washington. We actually get to celebrate our holidays. That doesn't feel like it always happens. So that gives Congress a little reprieve to figure out what they're doing. In addition to the grant programs that are supported under the federal budget, the discretionary budget, there were a number of what we call extenders in the Medicare space that were really important that expired October 1st and now have been extended, now also have a short-term extension through January 30th. Those include telehealth, right? So those telehealth flexibilities under Medicare that we have realized are so important to providing care to our beneficiaries, but also our Medicare dependent hospital designation, the low volume hospital payment adjustment, and then our ground ambulance add-on payments. We also saw extension of some of the mandatory funding for health centers and National Health Service Corps, in addition to what they get in their annual discretionary budget. So that's where we are with the health related and most of the federal government. Oddly, in the decision to reopen the government and that vote, Congress was able to agree on, there's 12 appropriation bills across the federal government that Congress has to develop every year, health being one of them. Another important one that we track on is what happens in the USDA space, because there are a number of health-related programs there too. So Congress was able to decide on a budget for FY26 in the USDA ag space. So these programs have been funded at these levels, the bullets on the screen, for the FY26 26 fiscal year, including some important money for loans to healthcare facilities, funding, grant funding and other funding for telehealth, and technical assistance program for rural hospitals. So we were thrilled to see this go forward, and we hope it is an early indicator for what we're going to see in the health space. So talking about the health budget specifically, the president, if you recall, way back in, feels like 1,000 years ago, but I think it was just March. The president put out his proposed budget for how he wanted to fund the government this year. He cut a lot of our core programs, including state offices of rural health and our flex programs, our area health education center grant program. So we worked a lot with all of you advocates to let Congress know how bad this would be for rural areas. And we were thrilled to see in the initial proposals that Congress has put forward, even though they haven't agreed on it yet, the initial proposal that they've put forward for FY26 sees level or in some cases increased funding for rural areas. This chart is just an easier way to kind of see that, maybe, depending on how you absorb information. So the key takeaway from this part of the conversation is that as Congress works towards that January 30th, having to make a decision on what happens with the federal budget, we really need them to put a new budget in place and not just carry over what they funded in the last year, because the FY25 budget is actually just a carryover from what they funded in FY24. And given the new investments that we're seeing in rural for FY26, we want this budget to be enacted because it would bring new resources to our communities. So that is something we're still very focused on and would love your help in conveying to the Arizona delegation how important the FY26 budget and these numbers will be to your communities. Okay, so pivoting to talk about the enhanced premium tax credits. This is the piece that had really been the crux of why the government shut down for as long as it did. And what are these? So again, just taking a step back, the health insurance marketplaces, it's a platform where you can buy individual coverage at kind of a more of a group rate, and therefore more affordable. But we know that it's not affordable for everyone, and that health insurance coverage is crazy expensive these days. So as part of that, there are what we call premium tax credits or subsidies that help people pay the cost of their premium so that they can afford care month to month. During COVID, there was an expansion of those premium tax credits that helped individuals whose income was over 400% of the poverty level. It also increased people who were under that level, increased the amount that they received to, again, pay that monthly premium. That enhancement that happened during COVID is set to expire at the end of this calendar year. And so the fight is to really continue that support for premium assistance for individuals and families. And you can see some of the numbers here on the slide of the volume of individuals that are impacted by those enhanced premium tax credits. And it does play out uniquely in rural areas, like many things in healthcare. There are only a few ways that health insurance premiums and individual offerings still vary. Part of that variation is based on geography, and part of that variation is based on age. And so we find that the cost of insurance in rural areas frequently can be a little bit higher, and we know that folks who live in rural areas tend to have a slightly lower income. And so the combination of that means that rural enrollees in the marketplace see a bigger savings through these enhanced premium tax credits than urban areas do. Therefore, if those go away, we're going to see a bigger impact on our rural populations. So this is this is again, the Democrats were kind of shutting down the government until the Republicans would take a vote on this. Unfortunately, they didn't get an actual vote, but they got a promise for a vote. So there's going to be a vote sometime in the month of December. We would very much, if this is an issue you care about, encourage you to again, talk to the Arizona delegation about how important coverage and affordability is in your communities and the importance of extending these tax credits. I can answer questions on specifics, but it is going to be a really interesting conversation because open enrollment for coverage has already started. So trying to make any changes for FY20 or calendar year 26 seems pretty darn hard at this point in time, which is what the Republicans are saying that they want to do. So again, I can go into more weeds if anybody has questions on this, but this is definitely something that we're very focused on for the rest of the calendar year, in addition to the federal budget. What else are we going to see potentially? I don't know if we're going to see any of these topics this calendar year, but the way congressional cycles work, as a reminder, is they're 2-year cycles. So every 2 years, if your bill hasn't passed, you have to go through the process of getting it introduced and getting support for it all over again. So what are we going to see the rest of this Congress? So we're just finishing up the first year of the 119th. Still a lot of interest on Capitol Hill about addressing drug shortages, 340B reforms, pharmacy benefit manufacturer reforms. So I very much expect to see something in those spaces, if not all three. Artificial intelligence is definitely something people are talking a lot about all over the place, including in Congress, and how do we have appropriate monitoring of it and implementation of it. There's definitely talk about how especially from the Republicans, about how they support the administration's MAHA of priorities and that focus on prevention and behavioral health, and I'm sorry, not behavioral health, chronic conditions, and the priorities coming out of HHS and Secretary Kennedy. We have lots of ideas of what they could focus on within the rural space. So to lift up a couple of our core bills, we would love to see them do some work on rural hospitals. And so there's a couple of bills just to share with you today. The biggie is the Save America's Rural Hospital Act. So if someone walked up to me and said, what is the one bill that we could pass that would help to stabilize rural hospitals and stop the bleeding, it would be this bill. It does important changes for critical access hospitals for all of rural like PPS or critical access, related to sequestration and bad debt. It would reopen the necessary provider designation. It would help to equalize kind of some discrepancies we see in co-payments for outpatient services for our beneficiaries that are treated at critical access hospitals and rural health clinics. It reauthorizes the FLEX program. So this is our big daddy. This is the one we really want everyone to support. Recognizing that it may have a cost that Congress doesn't necessarily feel they can invest in. We have a number of other bills, including things like bringing back the necessary provider status to allow for critical access or necessary provider designations with certain parameters. We also have bills that look at supporting technical assistance for rural hospitals so that they can keep their doors open day to day. In the rural health clinic space, we have a number of bills that look at modernizing the program, removing limits on the amount of behavioral health versus primary care we can provide, changing, or I should say, dealing with some of the changes to the most recent census definition and bringing those into alignment. We also have a real continued focus on telehealth and making sure that in addition to extending the telehealth flexibilities we have now, that we address payment parity issues and make sure that rural health clinics and FQHCs are paid in a manner that is adequate and is honestly equal to what they would get for an in-person service. We also are talking a lot about Medicare Advantage still. It has been the year of coverage discussions between Medicaid, the marketplaces, and Medicare Advantage. Still very much a hot topic on Capitol Hill. We have endorsed and signed on to a number of bills that work at tackling issues around prior authorization and prompt pay, because those are the things that we're hearing being the most challenging for our rural communities right now, or rural providers right now. We're also working on development of bills that would create floor payments for rural hospitals so that they would be equal to and not go less than what they would otherwise be paid under traditional Medicare. As well as issues around network adequacy, making sure that all of our providers are included in networks that plan set up, and that individuals can get services in their local community and not be steered to an urban area for care. In addition to those important, more coverage-focused Medicare, Medicaid, conditions of participation-focused bills, we are very much wanting to make sure that the core of the discretionary grants, that those programs stay sustainable and viable for the long term. And so that means authorizing. Authorizing gives Congress permission and gives the government permission to have the program. Appropriating gives them the money to run the program. So we need both. So we have a number of bills that are looking to either reauthorize core programs like the outreach program in the Federal Office of Rural Health Policy, or authorize for the first time pilot programs that have become core to the Federal Office of Rural Health Policy portfolio, like the Rural Residency Planning and Development Program and the RCORE program that works on opioid response. Okay, so what's happening in the administration? The big thing I want to touch on here is the Rural Health Transformation Program. I am sure this has been a hot topic in Arizona, just like it has been in many, many parts of the country. My guess is you have a pretty good overview of this program, but just at a high level, just as a reminder. The program, while it was talked about in Congress as a way to provide an offset for rural hospital losses in HR 1 under Medicaid, that's not actually how the statute was written, to be honest, as well as how CMS has chosen to roll it out. That is a $50 billion investment over 5 years, with half of it being baseline funding that goes to every state that applied for the funding. And I have heard that every state did apply for the funding. So every state that applied and has application that meets the baseline requirements will get $100 million every year for 5 years. That is set funding. The discretionary funding is the workload bucket, and that workload is the other $25 billion. And that workload funding will be allocated based on some rural factors that we'll talk about in a second, as well as the actual plan, the Rural Health Transformation Plan that each state develops. Those plans are developed on the 5 primary goals of the program, which are to support the MAHA, or Making America Healthy Again agenda, fostering sustainable access, so making sure that our hospitals, clinics, and others can stay viable, and helping them to do that. Some of this might actually include some provider payment, but there is a cap on how much can go to providers in the form of payments. A third area is on workforce development. I think every single state application I have seen has talked to this issue. So making sure that we are strengthening our ability to train and place individuals in rural communities, maybe changing policies around scope of practice. The fourth area is around care innovation. So really moving people towards value-based payment. How do we lay the groundwork to make it easier for individual and maybe independent providers to participate in value-based payment, potentially through integrated network models? And then the fifth area is around supporting technology, thinking about everything from how do you updates to your EHR and interoperability all the way up to integrating AI and remote patient monitoring in your care models. So I mentioned there are the three kind of categories of funding that CMS is looking at: that data-driven, which is the state metrics compared to other states. There's an initiatives-based element, which is your rural health transformation plan. Of those 5 goals, states could write to just under a dozen or so areas that specifically where they want to focus their efforts in their plan. And then there's also credit given if the state is able to change state level policy to support any of those initiatives. So we saw state level policy proposals in areas like scope of practice, in areas around food stamp policy, in areas, I'm forgetting all of them, but there was a whole range of areas that states could write to receive support and incentive to make those changes as well. When we're talking about the transformation plan, and I'm so sorry this says New York. It should say Arizona. I got my slides switched around somehow. But Arizona, so when you're looking at this first distribution of fund consideration, part of it is around core metrics that were outlined in statute and by CMS. How do you compare with other states? How does Arizona compare to other states? In things like your rurality, the financial state of your rural providers, et cetera. And Arizona scored, if the average was 1, scored slightly less than the average in terms of the rural facility and population scores. But that doesn't necessarily mean that there'll be less funding going to the state. It just means that that's kind of the bucket. That's how it'll factor into your score for that discretionary bucket. What else? There are some parameters, as I mentioned, around how the funding can be used. So there can be money for construction, but not new construction, and up to a certain level. Again, provider payments can only be up to 15% of the overall amount that states are receiving. And if you're going to make investments in things like your EHR, there's a threshold that can't be exceeded there either. So right now, those applications, as you all probably are very aware, were turned in on November 5th, and CMS is frantically reviewing them. The decisions on awards need to be out by the end of this calendar year by law, with the funding starting as early as January. And I think that's the work is definitely not over. While the 6 weeks states had to write their application was not nearly enough time to figure out how to transform rural healthcare. There's a good framework now in each state on how they're going to move forward. And from there, it will be really developing the implementation plan once CMS has signed off. All right, so much to talk about, so much to do, and we really want your partnership in that work. So we at NRHA, our goal is to make it as easy as possible for advocates to participate with us. And we have lots of ways we do that. We have leave behind materials that highlight bills, policies, data that make it easy to take to your local and national policymakers on how you want to see rural health changed. We have advocacy campaigns on our website where you plug in and just have to basically, you can personalize the message, but you can also use the pre-populated message, and it goes directly to the inbox of the individual you are sending it to. I do this for Montana because that is my home state, even though I'm out here in DC, and I get responses back. So I highly recommend using those advocacy campaigns. We have them on a bunch of different areas. All the bills that we've worked on and endorsed as an association are up on our website, again, sorted by topic. So you can see what we're doing in the hospital space or the maternal and child health space or the public health space around legislation in Congress. And then we have lots of regular communications with you all through our rural roundup that goes out weekly. It's our weekly policy, what's happened in Washington policy listserv. We have monthly grassroots calls that have conversations similar to this, but much shorter and with a variety of staff talking on them. And you can just reach out to us directly to advocate online, or I'm sorry, not online, with us, and we can help you advocate in whatever way you are looking to. And last but not least, I want to put a plug in for Policy Institute. This is our visit to Capitol Hill and policy conference that we hold every year. We have a day where you hear directly from leaders in the administration and in Congress. We have already put our invites out to Dr. Oz and others and hope that they will be able to join us. It also is a really good opportunity if you're interested in getting involved in advocacy, but a little hesitant. And I will tell you, I was a little hesitant when I first started this game too. It's a great way to go and do Hill visits and kind of learn the ropes without having to be solo, because state teams go together for our Hill visits. So if you have questions on that, definitely let me know. Our at a glance agenda is already available, and it's a great meeting if you care about rural health policy. So with that, I'm seeing a couple of questions come up in the chat, but I think I am ready for some Q&A. That was a lot of information I threw at you, so thanks for your patience with that.
Thank you so much, Carrie. The first one that came in is in regards to the Medicare and re-enrollment. It says, does this have to be done online? There may be people that need assistance. How will that assistance be available?
Yeah, it's a great question. So, the enrollment in in the marketplaces, that the lack of auto re-enrollment, you can do that online. There's a federal platform and a state, and in many states a state platform for that. But there also are folks in the states that can assist with that. The state health insurance, the SHIP programs, health insurance programs, and I can look up and send you the Arizona one if you don't have it already, is a great source for some of that enrollment data and support. I will say though, a lot of the programs that have funded navigators and other ones to help other people to help with enrolling in coverage, a lot of those have received payment cuts. So some of that has fallen to states and others to help to support. So no, you don't have to do it just only through line. A lot of community, there are some community resources available for that. And a lot of our healthcare facilities also have resources available, but we'll also need to be trained on changes and that kind of thing.
Thank you so much. The next question is asking if you could speak about the data points in which Arizona could help demonstrate disproportionate rural impacts when developing briefs and talking points.
Yeah, I think that is a great question. So, I heard a quote or a phrase the other day that spoke to me so much, and it was when you're doing advocacy, you speak or you talk to the heart to get to the mind, right? And I felt like that was a really kind of a perfect way to summarize. When we're doing our work, it's important that we can tell the story of the impact it has on individuals and communities, but also as a way to illustrate where there are challenges. And when you are illustrating those challenges, it's important to have the data to be able to show that. So, I would say the data point you use depends on which issue you're trying to lift up. We have a lot of resources and try to have a lot of resources available for you to do that. I'm going to drop a couple of things in the chat if I can talk and chat at the same time, which is a big if. On our website, this is going to the hosts and panelists. So Mariah, I might need your help on getting this to the larger group. But we have a rural health data page that has your individual hospital financial data that goes, so you can click on Arizona and you can get a list of, as of the beginning of this year, each of the hospital's financial status. That can be a powerful tool when you're talking about any hospital related issues within your state or that you want to advocate for. Further down the page, there is a rural health profiles tool that we've partnered with the National Organization of State Offices of Rural Health and Stroudwater Associates to develop. And it takes those three pillars I talked about, being kind of equity and opportunity, workforce, and infrastructure, and shows individual data indicators in, I mean, we must have 100 different indicators up there now. In each of those three pillars, it shows them at the state and county and district level. So that's a powerful tool, not only for advocacy, but for grant applications and other opportunities where you're trying to show need. So taking some of that data and coupling it maybe with some of the leave behinds, let's say on maternal health, and then looking at some of the local district maternal health data and marrying those together is a really powerful tool. And then if you're interested in both Medicaid, we have a congressional district health dashboard for Medicaid enrollment, and then also one that looks at the Federal Office of Rural Health Policy funding by state when you are advocating for some of those discretionary programs like the state offices or Flex or others. So lots of data out there. If you have any questions on something I didn't mention, please feel free to reach out and we will help you get to what you need.
Thank you so much, Carrie. And then lastly, I would like to open the floor to the director of the Arizona Center for Rural Health, Dan Dirksen. I believe he has a few questions as well.
Great.
Carrie, terrific presentation, and we so much appreciate your time with us today. And on behalf of Lupe and the other Carrie and Jen and others, Jill, we really do want to sincerely thank you for this important data. There's a few things that we'll need help with. Many of us on the line today participated in a webinar. Our RHTP plan was shepherded by the governor's policy advisor, Megan Kramer, and others. And in the last webinar, they indicated that they expect approval, by the deadline in federal law, the day before New Year's, and they expect to put out the request for proposals and the notice of funding opportunities through the designated state agencies, our state Medicaid program and the Office of Economic Opportunity and the Arizona Department of Health Services, probably starting in January. So a lot of people are searching for trusted data sources. How will CMS kind of interpret what's really rural? And we put some of these resources on our Center for Rural Health RH2P toolkit, including a map of what Federal Office of Rural Health Policy does. Do you have a sense that CMS will kind of use that updated data, the rural urban commuting areas data, the RUCA data, as part of their determination for that second bucket, as far as rurality and which sites and places?
Yeah, it's a great question. So it's a confusing question, right? Because the statute talks about the actual bill text, the law talks about rural in one context, but not necessarily in the sense of how funding needs to be allocated, if that makes sense. It doesn't really make sense, but it's how it is. And then, we know a lot of the states are going to have definitions that they're using too. And then to your point, there are the rural factors that CMS will be using to weigh part of the scoring. So those rural factors that CMS is using, the data they're using for that rural factors bucket, they laid out in the NOFO for each of those, what the data sources that they will be using. And I am going to drop another link in the chat. I can help you find it in the NOFO, but it's also, we had the University of North Carolina are the ones
Right.
that did the map of the analysis of the weighted scores and how everyone's going to um, fall out. And I believe if you go to the score estimates by state,
So the
you
Shep Center
the
data.
Shep Center, yeah, you can get there's an Excel file that I looked at a lot, and I'm pretty sure here I'm pulling it up right now. I'm pretty sure they have it by indicator, so you can kind of see there.
We can
Um,
follow up with you as we
yeah,
and the time we've kind of allocated. But one other quick question, maybe not so quick, but you talked about the enhanced premium tax credit, and there's a lot of
yeah,
discussion on this with the
yeah,
with some of our providers that are worried about, shouldering increased burdens of uncompensated care and charity
yeah.
care and things like that. Is there a trusted source of data really for that enhanced premium tax credit for how many by state? And yeah, the question's really around what can we expect as far as a decrease in the enrollment through these doubling and sometimes tripling of premiums that people are seeing, not only in those above 400% of the federal poverty level, but also for those that are trying to enroll right now during open enrollment in the
Yeah.
uh, in the Affordable Care Act, exchanges.
Absolutely. So there are a couple of sources. I will follow up with you on offline. I will say from a advocacy standpoint, the folks I think who have done the best on the messaging side of this is a coalition that NRHA is a part of. So we endorse them called Keep Americans Covered. And they have both state maps and calculators to help people understand kind of what that change would be as an individual or as a family. And so we've been using a lot of their resources. Um, the Kaiser Family Foundation in the last couple of weeks has put out some good stuff too that I can send you, and we tend to really trust their data. And then the report that had the map that I used in my slides was a Century Foundation that all some of these groups are more neutral and some have a little bit more of a partisan lean. The Century Foundation tends to have a little bit more of a left lean, but the woman who wrote that report actually helped to implement the marketplaces and was someone I worked with at HHS, so I trust her take on it. So that report is also a really good source to kind of understand the rural specific impacts of it. So I'll send you some of that offline, but I completely agree. This is an area that we don't talk a lot about in rural, but coverage is so critical, and it really would be devastating if people lost coverage. And there's so many rippling effects of people opting out of coverage because they can't afford it. I don't need to tell you about that, but yeah, so we'd love to work with you more on that as well.
Excellent. Thank you.
Well, I want to say thank you for your time. I also want to recognize that we didn't answer every question, so I'm sorry to those that we did not get to. That being said, these conversations are continuing to develop, and if you'd like to stay involved, we do have an upcoming Rural Health Policy Forum in Arizona talking about the specifics about Arizona. So that link is in the chat, and it'll also be included in the follow-up email. And then Lupe, if you want to say anything before we let everybody go.
Yes, just thank you so much, Carrie, for your powerful insight again and for your leadership. Thank you for all the information that you brought here, and we thank you on behalf of our entire committees here, like Dr. Dirkton said, together. We thank everyone who has joined us, and together we'll continue to fight the good fight. Happy National Rural Health Day. Thanks, everyone.
Thank you.
Thank you.
Bye.